Good morning, everyone in Southeast Asia. Good evening and night to others of you wherever you are. We're extremely pleased as the One Health Workforce Next Generation Consortium to come to you with the 6th in our series of COVID ECHO Community of Practice sessions. And we feel we're getting better at these all the time, thanks to your help and your feedback. My name is Professor Jonna Mazet, and I have the honor to co-lead this consortium with my colleague, Professor Woutrina Smith. And we want to welcome you from our home institution of the University of California, Davis, and thank you for joining us and being part of this important community. We also would like to thank the U.S. Agency for International Development for their wonderful support that allows us to all come together as academics, public health professionals, interested individuals of all disciplines, really supporting each other in this difficult time. Today we have an amazing slate of experts and we're going to focus on the really important immunity issues and interventions and updates on those as we're moving from the real chaos of being crushed by SARS-CoV-2 into a time where we're sort of a new normal, responding and trying to heal and preventing ongoing cases and illness. I would like to just start off by saying that we know and recognize that so many of you and your communities are struggling with very difficult tragedies, as we are here in the US, and we are with the anxiety that comes with the sheltering and the different activities we've been undertaking to try to be safe, comes a lot of new issues that we're grappling with and we've been talking about through our COVID. I think everyone is hopeful and excited about being able to go back to some semblance of what we consider a normal life, but we're going to have to adjust it. And one of the important things in thinking about that is, as we are getting our economies going, getting our businesses going, we have to be careful to maintain practices that keep ourselves and our friends and family members and community members safe. One of the very good models that has been pretty on target as far as projecting cases throughout this terrible tragedy has predicted that, at least in the United States, if we start to open up, we can stay fairly safe and not see a huge number of new cases if we maintain best practices of keeping ourselves at good distances from each other, wearing masks, washing hands, limiting our activities to just those that are essential. But if we should take the cue of the economy trying to open back up to change our behavior and assume that we're all just fine, we could see the number of cases and deaths almost quadrupling as we continue on. So we can't be complacent, and we all need to be the models of best practices, because we are, and most of you are, those academic leaders. So I would like to give a message of hope, and I feel we're moving into a very hopeful place, and today's session on immunity and interventions should be a step for us to understand that hope and what we can do. But I want to make sure that we all are really thinking and being careful about sending the right messages. So with that, I'd like to thank our amazing ECHO team who provide us this platform, and hand it over to my colleague, Dr. Bruce Struminger, to talk us through some of the ECHO benefits that we'll get with the logistics. And then I'll hand it over to Dr. Vipat, who is our our extremely valuable core leader for SEAOHUN, or the Southeast Asia One Health University Network, for your introduction and welcome. Bruce?
Thank you, Jonna, and welcome everyone to this 6th Southeast Asia One Health Network COVID-19 update in our series of these sessions. I'm just gonna go over a few housekeeping items. So one, we are, over the last couple of months, we've been meeting every 2 weeks, and we're building this community of practice across Southeast Asia and linking colleagues in Europe and the United States and beyond. And one way that really helps us get to know each other is by turning our cameras on so we can see each other during the session. So if your bandwidth allows it, please turn on your camera so we can all see each other and get to know each other face to face. But we do encourage you to keep your microphone muted during the session unless you're wanting to ask a question or make a comment. And if you can, please rename yourself by going up to the top right-hand corner of your little Hollywood square, clicking on the 3 buttons, and there's a rename option, and put your name and your organization so we can also get to know each other and what organizations we're affiliated with. There is a chat function, and if you're having technical problems, please chat Echo IT, and Helene with our IT team will help you as best she can. Also reserve the chat function for generally otherwise for questions and comments, and we don't need you to put your attendance in the chat. If you can, hopefully you're using the PDA participant app, and there were instructions in the announcement on how to download that. And to the right is the Start QR code. So for those who have downloaded it, please go ahead and take 2 seconds and scan the Start code. And then at the end of the session, there will be an End QR code, and that will give you a digital attestation of your participation. And also you'll get instant access to most of the PowerPoints that we had before we started. And I will stay on for a few minutes at the end as well to let people scan the Start code or troubleshoot if they're having any issues. All the presentation slides will be shared both through the app, but also by email after the session. So the session is being recorded, and your attendance is consent to be recorded, so thank you for that. There will be continuing professional development credits through the University of New Mexico, where the Echo Institute is based, and we're a member of the One Health Consortium. There will be a link in the chat at the end of the session, and there, I think, is also a link in the announcement, the most recent announcement that went out. When you get those CPD credits, which are instant, you'll have to spend 3 minutes taking a survey, and that we really value the feedback you give us to help us improve these sessions. We've been reading your comments, and we've been trying to respond to them, so please keep them coming. And with that, I'll stop sharing my screen and hand the microphone to Vipat Kuruchittham, who is the director of SEAOHUN. Vipat?
So thank you, Bruce. So I'm Vipat Kuruchittham. I'm the executive director for the Southeast Asia One Health University Network. So we are pleased and delighted to be co-hosting these sessions. This is our 6th session now with the One Health Workforce Next Generation team, leading by the University of California at Davis with the great support from the ECHO team and the sponsorship from the USAID. So for the one who are really new to us, let me just give a couple sentences of who we are. So what we call ourselves as SEAOHUN, Southeast Asia One Health University Network. We are a group of currently 81 universities from the 7 countries in Southeast Asia, from Indonesia, Malaysia, Thailand, Vietnam, Cambodia, Laos, and the Philippines. our goal is to try to working together to develop a resilient and competent One Health workforce by leveraging education, research, and training provided by our university network. So we're so pleased and delighted to partner with all of you to build the next generation of One Health workforce to combat emerging infectious diseases like the COVID-19 that you are experiencing now. So thanks for tuning back again and again. I also spread the news to the others because we really try to encourage and create a community of practice, so where we can share our lessons learned, experience, challenges, and discussions from one another. So with that, today we are so excited to have the speakers abroad and overseas from the Southeast Asia, both from the Vietnam and the Philippines, sharing their experiences. So with that, we always start with the global updates of the COVID-19 around the world. Let me introduce Dr. Brian Berg, who's Associate Director for the One Health Institute from University of California at Davis, to kick us off with the global update. Brian?
All right, thank you, Dr. Vipat, and welcome everyone. It's so wonderful to be with you again for the 6th time. Can you believe it? It's the 6th time we've been talking about COVID-19 and various aspects of this global pandemic. And tonight we have a really exciting session, I think, because we've finally come the full circle. Remember, we started with the One Health origins of coronaviruses, we talked about diagnostics, we talked about psychosocial issues and gender issues in the epidemic and pandemic, and now we're coming to immunity and interventions. And this has been an iterative process where we're really trying to allow the science develop as it goes along, so that then when we meet and talk in our community of practice, we actually have some data and some meat behind what we're talking about. And today it's talking about immunity, principles of herd immunity, and how we can get ourselves out from under this global pandemic. And this slide on my title slide here, I just took from BioRender. It's a wonderful resource for biomedical illustrations, and it talks about the different ways we can combat these kinds of pandemics. The top panel there is just showing unmitigated spread of any particular infectious agent. And then in the middle panel, and this is something I'm going to highlight today in my section, is a little bit about what we can do on the non-pharmaceutical side of interventions. So this is the hygiene, that's the social distancing, the physical distancing, the wearing masks and the like. And then our 3 excellent speakers that will follow me will talk about both vaccines and the insights that they're gathering from people themselves and their immune responses in their countries. So just a global update, according to WHO, we're now at 6.2 million cases. This is now 1.5 million more than when we talked last 2 weeks ago. The 2 weeks prior to that, it was 1 million more, and the 2 weeks prior to that, it was another 1 million more. So the pandemic is certainly continuing. But the good news in the SEAOHUN network countries, if you look at this chart of the increase in total cumulative cases of COVID-19 in your countries, it has flattened out. But that doesn't mean that the disease has gone away. We need to remain vigilant. I see many of you on the call wearing protective equipment. I assume you're working in a healthcare facility. So please, please, please take the appropriate precautions for your own physical well-being and safety. And just yesterday, I think we got the first large amount of data that backs up these recommendations. A large meta-analysis was published in the journal Lancet, the next slide here, that showed that for the first time for various coronaviruses, including SARS-1, classic SARS from 2003, MERS, the Middle East Respiratory Syndrome virus, and now SARS-2 or COVID-19, that these basic principles of hygiene, wearing of masks, both cloth masks like the one that I wear when I go to shopping at the grocery store, and then also N95s and other masks are effective. If you can see here, there's a link to this paper here in my slide. It should be active. If not, just copy paste it into your browser. But you'll find that within this, there's quite an extensive analysis of over 170 different studies that looked at these viruses and what you can do to protect yourself with basic hygiene principles. Those of you on the line know that my background is in hemorrhagic fevers and controlling Ebola outbreaks and the like. And really, physical hygiene is a huge, huge part of controlling those outbreaks. And COVID-19, it's the same. Very similar principles. It's physical distancing, wearing of masks to both protect yourself from inhaling viral particles, but also to protect others, because many of us are asymptomatic carriers of the virus, as we've talked about previously. So with that, just some links here back to WHO and some excellent resources on the constructions of basic masks, like the ones that I wear when I go shopping for food in our stores here, and then other wonderful resources on their website, and the links are there. But the key message is we now have data that does clearly show that masks and hand washing and physical distancing can work and reduce the incidence of the disease. All right, and as always, the last slide in my presentation is just a laundry list of various links to different topics that we've covered over the time together, and they very useful links to factual information if you have further questions. And with that, I will end my slides, and I will turn the podium over to my colleague, Mike Whelan, who is a program manager at CEPI, Coalition for Epidemic Preparedness Innovations, which has truly revolutionized the vaccine landscape for many important diseases over the past few years. And we're very, very honored and privileged to have Mike joining us to talk about the efforts that CEPI is doing in this space, and in particular because it is 2 a.m. for him, where he is calling in from. So a huge thank you to Dr. Whelan. So with that, Dr. Whelan, please.
Thank you ever so much, Brian. Really appreciate it. Can everybody hear me okay? And you can see my slides, yes? Super. Well, where do we start? I mean, what I thought I would try and do is give you an overview of who CEPI is, because some of you may have never heard of us. And then I was going to give you a brief overview of what we do, and then try and explain how we've ended up in the COVID-19 situation. And it dovetails very nicely into what Brian and colleagues have just said. So let's see, there we go. The Coalition for Epidemic Preparedness Innovation, CEPI, we were formed in Davos in 2017. And really it was the world's response to the Ebola outbreaks of 2014 to 2016. And everybody said, you know what, this shouldn't happen again. And guess what? It did. So we were funded with a mixture of public, private, and philanthropic money. So that included people like the Gates Foundation, the Wellcome Trust, the Sovereign Wealth Fund of Norway, and many others. And the idea, we have a rather lofty ambition, a world in which epidemics are no longer a threat to society. A big ambition, and some may say, reaching for the stars, but you know what? I think we were right. And what we try and do is accelerate the development of vaccines in 3 ways. So we want to be prepared. So for existing diseases, which I'll talk about in a second, we want to have something in the cupboard. We want to be able to respond, and of course, this is where COVID-19 comes in. And we want whatever we do to be sustainable. And this is massively important to us, that everything we do has to be available regardless of the ability to pay, because it's just not right that the richer companies get vaccines first. So when we started, we had a number of priority pathogens, and these were based on unmet need, but also ones which had epidemic preparedness. And Brian's already mentioned MERS, which was a coronavirus. So were we surprised we had another coronavirus? No, not really. But we worked on MERS, Lassa fever, and Nipah, all of which, when they happen, are devastating, but largely ignored by the pharmaceutical companies because you simply can't make any money on them. So we had several programs in those. Then we did the second call, well, actually a third call for proposals, which was chikungunya and Rift Valley fever. And that's how I had the pleasure of meeting Brian in the first place, because we worked together on a Rift Valley fever project. And then we had another call for proposals, and this was for disease X. So was CEPI surprised that we had an outbreak such as the one we've got now? No, not really. That's what we were set up for. So the current portfolio of vaccines that we're working on, and this is pre-COVID, and I'll show you an update of the slide in a minute, had a number of different technologies, and the idea was to take them from preclinical all the way through to the end of a phase 2 trial, and then perhaps produce a stockpile, and that stockpile could be used if there was a big outbreak. Now we're going to have to change that model, obviously, but that was initially for these diseases of unmet need. And you can see we've a wide variety of colleagues all over the world, and a wide variety of technologies, including things like recombinant viruses, recombinant proteins, inactivated viruses, DNA vaccines, RNA vaccines, pretty much everything. As a group, we're quite agnostic about these things. We don't think one technology is better than another. We're prepared to try them all, and we're well funded enough to take them all the way through. So what we don't do is fund a small body of work and then just forget about it. We want to see the long-term development of these projects. So we will take them from preclinical, phase 1, phase 2, then really getting ready for an outbreak. And then at that point, that was kind of where we were stopping. Because A, we didn't have the funds to take all of them through to registration, and B, it probably wasn't really necessary. And if we use Ebola as a paradigm for that, yes, we now have 2 licensed Ebola vaccines, but actually that was a result of working from a stockpile. It never went through a formal licensure procedure. It never went through full PQ and so forth, which is ultimately where you want to be, but it was really done because it was used in the field. And that was the model we were using. And also importantly, and I've put at the bottom, some of the other things that we also fund, and that's things like the development of assays and standards. So you can develop a vaccine all you like, but how do you know it works? So unless we've got an international standard, how can we compare all of our different platforms? We need to know, where's the disease going to occur? Where would we do a clinical trial for Lassa fever, for Ebola, or whatever? Obviously diagnostics, how do you know the disease is there? And of course, regulatory. Regulatory is massively important to us, because how are we going to get these things which conventional licensure probably isn't going to fit? So this was the sort of pre-COVID update of what we've done. So we developed prophylaxis and response vaccines. We worked out these cross-cutting activities for standards and so forth, worked with regulators, and we're all about coalition, and that's what the C in CEPI stands for. We want to work with our partners to try and develop these things. But that was then, and this is now. COVID-19 is different. COVID-19 doesn't discriminate against the rich and poor countries. A vaccine is needed by everybody. So our idea of a phase 2 stockpile in this particular instance isn't going to work. We need a licensed vaccine, and that way it can be used outside of a clinical trial protocol quickly. So we've had to change. Now, I mentioned we had some rapid response platforms, and I'll explain about those in a minute. We also issued a new call for proposals. We actually did this in February, and we took 14 through, we took 28 through due diligence, and we did that in less than 7 days. And we've got 10 of those funded already. We had very high level engagement with the WHO and other NGOs, people like the Gates Foundation and the Wellcome Trust have been critical to what we do. We also issued a call for further funds from the World Bank, and we actually think we need at least $2 billion to take this through, to take 2 or 3 through to licensure. And we're pretty much there at the moment, and we anticipate there's going to be a further fundraising. We have over 10 live active COVID projects, and we've also done a lot of enabling science, and enabling science in this is massively important. So our goal is we're seeking to manufacture and license at least 3 to 4 different vaccines, simply because there's 7.8 billion people in the world. How can we make enough vaccine in a year? I wanted to very briefly touch some of our platform technologies. This is actually one I'm a project leader on in Australia, where we're looking at a molecular clamp platform. And what this works in all type 1 and type 3 glycoproteins, which are found in many viruses, including a lot of the coronaviruses. And what happens is the pre-insertion proteins actually are metastable, they move around. And so the immune system finds it very difficult to make an antibody to it. Once it inserts, it changes conformation, and you can make loads of antibodies to it. That's fine, but it's also after you're infected, so it's not terribly helpful. So what this does is this locks it in the pre-insertion form where you can make a response to. We had this project up and running. We were working on things like RSV, flu, and MERS. But because we had the technology, we said, right, in January when COVID hit, we redirected their funds. They've been working on COVID-19 ever since. And in fact, we will start clinical trials on our SARS-2 vaccine in about 20 days from now. Similarly, our colleagues at Imperial College have a very nice technology using self-amplifying RNA. This is Professor Robin Shattuck in the picture. And what he and his colleagues have worked out a way of doing is it's almost like a safe virus, if you like, which carries the SARS-2 insert and then amplifies in vivo. Similarly, we also have a true RNA vaccine from our colleagues at CureVac in Germany, and they're doing something very similar. And again, they'll be in clinical trial in about a month's time. I mentioned enabling science, and in the COVID-19 outbreak, this is massively important. So we've had to use cross-cutting across all of our vaccine projects. So we're looking at things like serum collection, developing an international standard. Our colleagues at the National Institute of Biological Standards and Control here in the UK actually already have an interim standard that we've already sent out to our partners. So we can have that comparison. Because we already know we get seroconversion in patients and we know what we're looking for. We had to procure the virus. I was actually involved in this when I was in Australia, and we managed to get one of the first isolates from Melbourne University, which we then shared worldwide so people can actually do the test. They can use it in animal models, they can develop virus neutralization assays. We had to develop new animal models. And we've also developed centralized testing where we can send samples worldwide. Of the animal models, we were starting from a very low base. There was just nothing. Initially, we started with the ACE2 transgenic mice, which is nice. There's several different versions of it, but A, the numbers are simply not there. And B, there are slightly different versions of it. Probably the best version's got the mouse ACE2 leader sequence and then the human ACE2 transgene. But there's several different versions and it's very complicated. It works in ferrets, and we've been able to show lung pathology and virus shedding. We've funded a number of groups worldwide to do this and to have this as a resource for our colleagues. Similarly, we've been working in non-human primates. It seems to work best in rhesus macaque, although there are some data for cynomolgus as well. And probably one of the best models is actually Syrian hamsters, and this was developed with our colleagues in Hong Kong University. And the Syrian hamsters, like the ferrets, actually show aerosol transmission. So there's lots of little pictures of hamsters wearing masks and so forth, but actually they have shown it. But we've demonstrated, it's well known that making a vaccine from SARS-1, there is a potential for immunopathology. So animal models have got to be done before we release anything into humans. Serological standards, well, I've already mentioned that. There is an interim standard already available. But we need a definitive method for comparison. So things like we funded development of virus neutralization assays, whether that be on live virus or pseudovirus, and also standardizing endpoints for ELISAs and having a reference that everyone can use. So what was our response? Well, very close interaction with WHO and all the epidemiologists worldwide. Engagement, we think it's really important that we engage multinational companies very early, because it's all very well having a great technology, but if we can't scale it to huge numbers, it's just not going to work. So a lot of the technologies that we've chosen have been chosen for speed and scalability. That's not to say that there's other technology we couldn't have used, but if we can't scale it, we didn't do it. We've actually got another call for proposal out. And I want to talk about the ACT Accelerator. I'm going to come back to that in a second. So all projects that we have will have at least a phase 1 by year end. Almost all will be phase 2 by the end of the year, and quite a number will be in phase 3. The ACT Accelerator, this is massively important. This was launched about a month ago by the European Union and CEPI and of course the WHO. And what the ACT Accelerator is, it stands for the Access to COVID Tools Accelerator. And we as CEPI have always believed vaccines should be made available to everyone. The ability to pay is irrelevant. So what we would like to do is share everything, and we would like vaccines to go into a global pool. That global pool will then be sold by Gavi. Gavi, who as we know have done fantastic work worldwide in things like the elimination of polio and rotaviruses and so forth, Gavi are going to do this with us. So CEPI on the left will be in charge of developing the vaccines and making sure they get manufactured. Then we will put all of those vaccines into a pool, which Gavi will then send worldwide. The idea being we want to get away from what we call vaccine nationalism, which happens. We know it happens. Countries understandably want to look after their own people. And so they will fund vaccines for their country first and then everybody else. We're trying to get away from that. It's going to happen. We know it's going to happen, but we prefer there's a pool that we can then give it out. And if you think about it, it's largely a numbers game, really. That within the time frame of getting this thing out, we need to prioritize people like healthcare workers and those that are most vulnerable to get the vaccine first, regardless of where they are in the world. So we would like to do it in this ordered manner. So everybody will get it. It's just a question of the order, and that's where Gavi comes in. You can see this is President Sarkozy, and many, many of the world leaders were involved in setting up the ACT Accelerator. And in fact, today in London, there is a huge fundraising meeting going on for Gavi to fund this initiative, which we're most supportive of. So, as I said, our portfolio, we have these rapid platforms, which I've told you about, several new technologies. We're largely agnostic about the technology. We'll try everything, but it had to be scalable and it had to be working. The engagement of multinationals is vital in this, otherwise we just simply won't get the doses. So we need billions of doses by 2021. So the portfolio slide I showed you earlier on has now changed quite dramatically, and you can see in the middle there's an awful lot of COVID work. We've actually got about 10 platforms here, and we've got recombinant proteins, we've got inactivated viruses, we've got recombinant viruses, we've got DNA, we've got RNA, everything. So sustainable manufacturing, again, is massively important. It's all very well making these things, but it has to be available to the people that need it. So we want worldwide manufacture, and we want both stockpiles and active manufacturing everywhere in the earth. And it has to be available for all. Also, we do want fill-finish capacity, of course. You can have all the bulk you like, but if you want to have a licensed vaccine, it needs to be filled-finished. There's only a finite capacity of that, and there's only a finite number of glass vials in the world. How do we deal with that? So, I know I've rambled on a bit, so I hope I haven't taken too much time. We were designed to respond and try and protect the world from epidemic threats. And guess what? This is one. This is the fastest vaccine program in the history of the world. And we are right in the middle of it. And we value our colleagues worldwide to try and help us get through this. And with that, I think I'll leave it. Thank you very much for your attention.
Thank you, Dr. Whelan. That was great. Again, a tour de force from CEPI in trying to push as many vaccine candidates as possible towards the finish line, and that is hugely important. So I have many questions for you, actually, and there's some that came in the chat box. But I think let's first hear from our other colleagues and then have the Q&A session towards the end. So I'd like to turn the podium over to our colleague from Vietnam, Dr. Nguyen Thu An, who is the country director of the Woolcock Institute of Medical Research. Dr. Nguyen, please share us your experiences and research efforts from Vietnam, please. Podium is yours.
Good morning and good evening, everyone. Thank you for inviting me to share the information from Vietnam. As you all know that Vietnam, although have a high population of 96 million and a long land border with China with high volume of trade, so far we have been able to keep the number of COVID-19 cases as low as 328. Of those, more than 92% of patients recovered and no one died of COVID-19. And in the past 48 days, we haven't found any new cases in the community. Most of the new cases are those travel from other countries back to Vietnam. So looking at that information, it suggests that the level of immunity in the community in Vietnam is low, very low. So what we have done in the community to control the epidemic, I could list 5 key interventions among many others. The first one is the country has taken an early, very strong and multi-sectoral response. The whole community was mobilized to take the action. And the second intervention is mass communication was done widely to provide transparent information and to gain trust from people, so everyone comply with the recommendation from Ministry of Health without asking why I have to wear a mask or why I have to keep distance. The third approach is we introduce quarantine, mandatory quarantine 14 days for all the suspect cases and travel from other countries back to Vietnam. We tested targeted high-risk groups, including those who travel from the epicenter who contacts with the confirmed cases, regardless of their symptoms or not. And we conducted rigorously first-hand and second-hand contact tracing. The fourth intervention is the country has put in a 3-week lockdown nationwide when there is a sign of community transmission that we couldn't find source of infection for some cases. And finally, the government introduced a social and financial support scheme for vulnerable community to make sure that they have enough food and they have enough essential supply to stay at home. So since the 4th week of April, the country lifted the lockdown, and it was a bit chaos in the first 1 or 2 weeks because we are not sure if there will be a new case. When there's a person with fever lasts for a few days, the whole city or province got to be nervous and many people were tested. But so far, things settled down, children back to school. And as you can see, people go to restaurants to have a meal, but there's a physical barrier between the customer to prevent the infection. Workplaces are fully opened, and domestic tourism is promoted. However, the border is still closed, except the overseas returners and high-skilled foreigner experts who are allowed to get into the country with a mandatory quarantine for 14 days. So the next step, what the country plans to do, we still continue implement the quarantine and test travelers return to Vietnam and strengthen the border restriction. And we don't know whether what is the level of immunity in the community. So some serology prevalence will be conducted in the coming weeks. Very shortly. Furthermore, the country is putting effort to investigate a viral vector vaccine that was tested among mice and showed that the vaccine was able to promote the production of antibody, and it goes to the next step of the investigation. The country, our group is also planned to develop a plan for rolling out vaccine at a large scale in the country to allow equity in access to vaccine for everyone. And one of the very important action is to have the economic recover and developed for the country. And the government also have a plan to reboot all the responses that I mentioned above if there's indication of the transmission of COVID in the community. Thank you.
Thank you, Dr. Nguyen. Thank you for that overview in Vietnam. And I have a few questions for you as well that I'll turn to after we hear from our next speaker, who is from the Philippines. So I'd like to welcome now Associate Professor Dr. Lali Alentajan Aleta, who's from the University of Philippines College of Medicine, to tell us about her work and the situation in the Philippines. So please, Dr. Lali.
Good morning, everybody. Good evening to those in Canada and the US. I'd like to thank you for giving me the opportunity to share what we have been doing in the Philippines. I am a clinical immunologist, so I handle patients primarily. So our work is really focused on taking care of patients with COVID. So for updates of COVID immunity issues and community interventions in the Philippines, I would just like to start off with showing you our latest data on COVID cases in our country. So as of yesterday, 4:00 p.m., there were 19,748 total number of cases with 4,153 recoveries and only 8 deaths reported today. So suffice it to say that 94% of our cases are mild and less than 1% are severe and in critical conditions. So we're seeing a lot of infection rate, a high infection rate, but mortality rate seems to be declining over the past few weeks. The confirmed COVID cases in the Philippines, when you total them, most of the cases that are tested on a certain day has to do with a lot of the backlogs, but the red areas show the more recent or the fresh cases. So we're keeping it at a minimum. So we're saying that we're probably going into a plateau, flattening the curve. That's why we are on our second day out of quarantine. We had our lockdown early in March. And only 2 days ago, starting June 1, the country has gone back to normal, at least for Manila, the national capital region. It has only been our 4th day of our new normal. So we have to wait and see how this will affect transmission rates, infection rates of COVID-19. So I am part of the University of the Philippines, Philippine General Hospital, and this is our department. And our center has been converted or has been identified as one of the 4 COVID centers in the National Capital Region. And all our residents have been mobilized to focus on COVID patients. Our hospital has been transformed into a major center for moderate to severe cases of COVID. A lot of the hotels around have been converted into places where our healthcare workers can get off from work, because the work system of our hospital has also changed so that we can have 1 week on duty and 2 weeks rest for possible infection and time to quarantine ourselves. So it's like trying to simulate that if you were exposed, you might have been infected. So you all automatically have an automatic 14-day quarantine period to see if you develop symptoms before you can go back to work. And a lot of help from the private sector has made this possible. The gymnasiums and schools around the areas of our COVID centers have been transformed to be quarantine centers as well. So I think because of the experience of Italy and China, we were more afraid to have worse to have a worse scenario, because we knew that our healthcare system was not or will not be able to address a massive surge of COVID cases. And that's why early on in March, the whole country tried to prepare for the worst. And I guess we're doing a good job because again, the mortality rates have decreased, the admissions have been kept to a manageable number. We have our healthcare system, we say, hasn't been overwhelmed. And just to show you that we already have a guideline on how to treat moderate to severe cases of COVID as early as March. And we have accepted the use of a lot of medications for COVID, like your hydroxychloroquine. We have accepted the use of tocilizumab and your antivirals, all under a study or study protocol, and all patients would need to consent to be given this treatment. And on top of that, our institution has allowed us to give our immunomodulators like our IVIG and our convalescent plasma, again, under a study protocol. So our patients are able to get most of the drugs available for COVID-19, and we're hoping that, we can further decrease the numbers of mortality and morbidity. So I would just like to share that in the Philippines, we have also developed our own PCR kit to diagnose or to detect the virus, and it is through our National Institute of Health. And I am part of the Philippine Society of Allergy, Asthma, and Immunology. And we are a group of clinicians, both internists and pediatricians. And we have come up with a review article on all the possible immunomodulators for COVID-19. And this review article should help our colleagues determine what is the best immunomodulator for our patients admitted for moderate to severe COVID. And with that, thank you for allowing me to share this with you.
All right. Thank you, Dr. Lali. That was great. So this is really exciting because we've had three quite different presentations, which is fantastic. That's what this is all about, right? We're learning from each other. We know clearly that none of us on this call have all the answers. We all need to work together, and together we can find solutions to this gigantic problem that we're facing. So I think one question, I'll just kick it off back to Dr. Whelan. I'll just sort of go around the question or the speakers there. And you mentioned that you have several vaccines in the pipeline. Many of those are going to hit clinical trials in a month or soon, or some are already there. Are there, as you broaden out the clinical testing paradigm for your vaccines, are there ways that you will reach out to other countries beyond the initial study design to get involved in these, like our colleagues from the Philippines or Vietnam or elsewhere, to ensure that the vaccines that you're working on are effective in many different countries and many different population types and all those kind of things? Over to you, Dr. Whelan.
Yeah, very much so. You're absolutely right, Brian. For a very good example of that is probably the Oxford trial, which you've probably heard about, which is the ChAdOx1 based trial. And what they were trying to do was actually try and catch the wave of COVID here in the UK. Now, whether or not that's possible, we're not sure. And what we're hearing, and it's not finalized, but what we're hearing is they're going to start branching out into other countries just to try and get that efficacy signal. So really, we're having to use very adaptive trial designs. We often call it, flying the plane while we're still building it. That's exactly what we're doing here. So that in order to get that efficacy signal, because they have a control arm where they use, I think it's a meningitis vaccine. So if that control arm would have to have an attack rate of about 5% for them to get their endpoint, so they will very likely have to expand that into other countries to get there.
Yeah, I agree. Yeah, I think that's, you know, in my limited experience in vaccines, it's one disease in a relatively regional kind of context, but this one is global.
But this one is different. This one is
exactly.
different.
So, Dr. Nguyen, I really enjoyed your presentation on the situation in Vietnam and thinking of how we will roll out these vaccines once they're developed and they're created and they are shown to be safe and effective. How do you think in a country like Vietnam you would actually deploy the vaccine? So, what should we be thinking about as a community here about, well, who should get the vaccine first? Because someone has to be first in line and someone, well, has to be last in line just because. Are there thoughts from you or from the country about how you might rationally distribute the vaccines?
Thank you, Dr. Bird, for the very important and very difficult question to answer. I haven't seen any plan in the country on how vaccine should be distributed, but in Vietnam, we have a very strong primary healthcare system, and we have an EPI program that distributes the vaccine to children in the community, and it's equally distributed regardless whether children are in the city or in the rural area. We have common health station with sufficient facility to store vaccine for short time and even to vaccinate children at home. And I'm thinking that we could utilize the system. Of course, the system is for children, and we are talking about vaccination of whole population, including adults and elderly, which require a further investigation and capacity building, but building on existing large-scale vaccination program could help us to rolling out this intervention very quickly.
Yeah.
I had a question for Dr. Tu.
Hang on, if you could just type your question in the chat box, we'll catch it and we'll come around to it.
Okay.
Yeah, sure. And then Dr. Laura, from the Philippines, have you heard any discussions about that same question about how will we distribute the vaccines once they're available?
Well, in the Philippines, we just recovered from a very massive issue about the dengue vaccine. I don't know if you've heard of that controversy about the dengue vaccine in the Philippines. That's why, because of that, a lot of people are averse to having any kind of vaccine. So as a clinician who might recommend, COVID-19 vaccine, my first question is, knowing that the virus mutates, we don't even know how often it will mutate. We don't even know if you recover from the illness, you will be immune for maybe 6 months to 1 year. My question as an immunologist is, what's the most antigenic part of the virus that will give you a long-lasting immunity? That's my first question. And because, again, of the Dengvaxia scandal, people are now going to be very critical about the effectivity and the safety of the vaccine. And knowing that, because then our colleagues argued, why were we the first to be given the Dengvaxia versus other countries? And because, again, of that experience, we want to be very, very careful.
Yeah, I completely agree with that. Maybe I'll send that over to you, Mike, if you want to speak to that a little bit about the balance of speed and safety and efficacy and those kinds of things. That's critical. Critical.
Thank you. I mean, thanks for the opportunity to reply to that, because that is an excellent point. And we fully understand. I mean, yes, the anti-vax movement is a real problem, but we are not going to get out of this without a vaccine. I mean, herd immunity to get the levels we need is simply not possible without a vaccine. So you're right, we have to be very careful. You asked a couple of questions. The most antigenic part, almost everybody seems to be using the S protein, the spike protein. And there's a number of people who are only using the receptor binding domain of that spike, although most people tend to use the full length spike. However, this is kind of related to your second question as well, because as you probably know, in SARS-1, immunopathology was seen in animal models. It wasn't seen in humans, but it was seen in animal models. And it seemed to come from the nuclear protein and potentially the base of the spike. So those two areas were noted. So hence all of the animal studies that we've been looking at, that's what we've been looking for, because we cannot make that same mistake again. And Dengvaxia was associated with pathology. So we cannot let that happen. So all of our studies, we're being super careful, animal models first, and looking for pathology throughout all the trials. Thank you.
Yeah, thanks for that. I think the impacts of vaccine safety on uptake of vaccines is so important. In my field work across Africa with Ebola viruses, people being afraid to get vaccinated, even though we know the vaccines are safe and effective, is one of the greatest barriers to turning down those outbreaks and finishing them for good. It's a tremendously deep challenge. So I think, just looking at my notes here, where to pivot to next. I guess we could think about, from Dr. Lara's standpoint, since part of this is on immunity to the virus itself, or the immunopathology. As a clinical immunologist, I'd like to hear your thoughts, and if you've seen any of the cases of the childhood inflammatory type disease that's been reported, or in any of your other patients in the hospital there.
Yes. Early on, we were asked about the similarity of the cytokine storm in COVID-19 versus the H1N1 similar like cytokine storm in children. And well, I looked at the pathophysiology, it seems different. In COVID-19, there's a lot of interleukin-6 hyperactivity and interleukin-1 and TNF alpha. But again, that's what we're trying to curb, because most studies for COVID-19 just assumed everything that was relatable to SARS-CoV was the same for COVID-19. So that is the assumption, that if it works for SARS-CoV, if that's the pathophysiology of SARS-CoV, then that should most likely be the pathophysiology for COVID-19. And so looking at cytokine storm, as immunologists, we were recommending that you give your treatment early on, because once you are in the middle of the cytokine storm, then it's most likely any treatment given in the middle of the cytokine storm would most likely fail. And studies right now are showing that it's no difference giving the immunomodulator or not giving the immunomodulator if the patient is in a severe type of cytokine storm. But anyway, we're trying to curb that. And I understand that it's genetically predetermined. You cannot predict by clinical symptoms or by signs who is going to go into cytokine storm. That's why it's crucial to understand that the virus may be harmless except for people that are predisposed to develop your cytokine storm. That's why probably we're also seeing a lot of mild cases, a lot of asymptomatic cases with COVID-19. So we're looking at less than 10% of patients who might die of COVID-19 simply because they are genetically predetermined to go into cytokine storm.
Yeah, thank you for that. And I think it's very important. I mean, part of where we're here together in our community of practice, this is a community of practice of One Health practitioners. And we always should keep in the back of our mind that every virus and every pathogen and every new disease entity that we come across as these viruses emerge from wildlife or other sources, they can and will be different than what we've known before. And we have to go with the data we have in hand. That's what we do as scientists, but we must push ahead and work together to find the new differences, the subtle differences between in this case, SARS Classic, SARS-1, and now SARS-2 COVID and COVID-19. And accept that things can be different and move ahead, and don't get stuck in the thinking of the past that it should be just like that in the future. That's a very important point that I think we should keep in mind as One Health practitioners. So Dr. Nguyen, we had several questions come in for you in the chat box about the community surveillance activities in Vietnam. And one thing you said really caught my interest in it was that as you do active surveillance or passive surveillance in Vietnam, looking for the imported cases, so now you're into the phase of imported cases. When you have a community-acquired case, then you will trigger back many of these quarantine and other lockdown type measures. So could you speak, one, to how the country is engaged in this active surveillance project or the program, and then what would be the triggers that would make the quarantines and lockdowns come back?
Thank you, Dr. Burt. The surveillance activity hasn't been, the community surveillance activity hasn't been conducted in Vietnam yet. There are two groups is working on the plan to do it. However, the active case finding has been done since the day 1, day 0, or even before day 0 of the COVID pandemic. And your question is very interesting. I think that so far we're still doing quarantine and contact tracing if there is a confirmed case found. For example, we have imported case isolated in the hospital. And recently we found a man who tried to come into the hospital and sell some stuff for the patient. So they exposed with the patient. And that man and his family was quarantined immediately and tested for COVID-19. So far the whole quarantine and contact tracing and testing of high-risk group is still being implemented. What additional intervention will be implemented is to do a surveillance in the community to trigger if we can find any case with antibody or positive real-time PCR test. And your question, you asked me about when the country will return to lockdown or social distancing. I think that when the hospital found a case that we couldn't trace the source of infection, then a small geographical area will be locked down, and that could be a little bit different from other countries. We do not immediately lock down a large area, but a small area of around 10,000 residents will be locked down. And when you say lockdown, it doesn't mean that people have to have difficulty in life, because the government will bring food and essential stuff, even the healthcare, or say like in one commune when there's a pregnant woman going to in labor, then they bring the doctor into the community to support. So I hope I answer your question.
Yeah, yes, that was great. Thank you very much. That's really important. I think we can't lose sight of the people. I've said it many times, the outbreaks start in communities and they end in communities. And communities are made of people, just like all the faces I'm looking at right here. So if someone gets sick and is diagnosed with this, and we do have to lock down or physically restrict movement to protect the rest of the population, we can't forget about those people. We have to provide them food and medical care and all the things that are essential for life. Otherwise, we're not really doing any good, in my opinion. We've lost our humanity in trying to stop a disease, and that can't happen. When we're thinking about the complexities of this global pandemic, which is just really stunning when you think about the numbers and the logistics of that, a question came in for our CEPI speaker about how you see the biggest hurdles in managing so many different projects, and how do you try to organize that effort at such a large scale level, because it seems daunting to me.
Yeah.
Back to you.
Thanks, Brian. Yeah, I saw this question. Was hoping you weren't going to ask that one. It's incredibly important, this one, and there's so many elements to it. First and foremost, what's the regulatory pathway that we can get a safe vaccine out to everyone? You know, and what Laura said was absolutely right. So what regulatory pathway are we going to use? Is it going to be some sort of emergency use? Is it going to be a full efficacy trial? Is it even going to be animal rule? We think it probably will be an efficacy trial, but again, nobody's really sure, and we need worldwide homology between all of the regulatory compliances. We also think, how on earth are we going to get enough vaccine in time? I mean, if, for example, and we just did a back of the envelope calculation the other day, if, say, we wanted 300 million doses of one particular vaccine, if, given the standard rates of expression of these things, you would need something in the region of 122,000 litre runs to get 300 million vaccines. Now, there are 7.8 billion people in the world. So one vaccine is not going to cut it. We're going to need maybe 4 or 5 worldwide. So how do we get enough, and how do we prioritize who gets it first? And that's where the ACT Accelerator comes in. So there's a number of moving parts.
Wow, I mean, yeah, when you think about the scope of this, it's staggering. Do we even have enough syringes if the vaccines need to be administered subcutaneously or intramuscularly?
There's a worldwide shortage of glass vials.
Right.
So we're actually looking at different technologies that we could use instead of glass vials, because how do we vaccinate the world? Nobody's ever tried before.
Right. Yeah. The scale and scope of it, rolling out an intervention on a global scale is something that requires, I think, truly harmonized international, well, both leadership, but financial support and regulatory streamlining. I think that's a very critical piece to this thing. So going back to Dr. Laura, not to put you on the spot, but thinking about the hospital care of patients and the things that you've done there in your experience, what would you say are some of the greatest challenges that you might want to share with some of our other medical colleagues that are listening in, that are lessons learned or key things that you know now that you wish you had known 3 months ago or even longer? Yeah, please.
Well, yeah, with COVID-19, this definitely is unprecedented. And because we saw what happened in Wuhan and in Italy and even in the US, in New York, we did not want to be in that position. So I guess for that, I would say our government and our hospital was proactive. We literally converted our old hospital, which survived World War II. We converted it into a COVID center with, HEPA filters, negative pressure oxygen, limited the hospital beds. We started with the infrastructure, and we had to let go of our patients. We had to transfer them to other hospitals nearby, because our hospital is the biggest training institution in the country. We had the most number of patients, and most of these patients are charity patients. So we had to transfer them. A lot of manpower, a lot of dedication, work 24/7. Doctors and residents, trainees were willing to serve, and not even looking at compensation, hazard pay, none of that. All we really wanted to do was be ready for the surge of COVID-19 patients. And well, admittedly, our country is a very prayerful country, and so far we really haven't overwhelmed our system, at least for our hospitals. We haven't been overwhelmed, and our healthcare workers surprisingly have been well, considering that they have been exposed to the most severe cases of COVID. There's a very, very small percentage of our healthcare workers getting sick, and our hospital really, and a lot of the hospitals really try to give the best protective equipment, protective your PPEs to all the doctors, nurses, residents, and even the training of our medical doctors had to be adjusted. And these interns who were not allowed to help in the hospital itself, they were manning the telecommunication arm of our hospital. They were answering calls, giving patients who were calling advice. So it was really a big, we call it bayanihan. Bayanihan is everybody's helping out in their own little way. So nobody really wanted to not believe that COVID-19 is going to swamp us. Everybody believed it will swamp us. That's why because of this fear, everybody complied and everybody helped. So I guess that's one major thing. When the experts say that it is going to be a very devastating thing, don't doubt. Just do what you're told to do. If the government keeps you on quarantine, just stay at home. And I guess everybody helped in that aspect. So I guess we're just very thankful that it's not as bad as we expected it to be.
Yeah, thank you for that perspective. I think that's important, a voice to hear in this, that accepting that the problem could be huge and taking proactive steps to manage it on the front end is important. For these kind of things, we can't put our heads in the sand and pretend that the thing is not going to happen. The more we're prepared, the better. And I do applaud the medical community around the world for being proactive as much as possible, given the resources they have. I think medical practitioners around the world should be thanked and congratulated for the work they've done so far. I'm sure it has not been easy. So thank you for that. We did have a suggestion in just a few minutes here of asking Professor Camilla Roa about his experiences or her experiences. I'm sorry, it came from a participant. I'm not sure if the Professor Roa is on or not, but
yes, yeah, Professor Roa had to leave, or
he did. Oh.
Unless he's still here.
Yes, I'm a colleague of Dr. Aleta and Dr. Mike. So what I can just add maybe is our experience of repurposing facilities on tuberculosis to also now be used to handle COVID. In particular, we have an old building. It's ideal really for infectious disease quarantine. Tall, high ceilings, big windows. No need for air conditioners, so we have good air exchange, and we are housing asymptomatic and mild positive cases until they are well enough to go back to the community, so they will not add to the problem. In addition, as also being asked before, as a clinician, there are things now that I do which I never had the chance to try before. I mean, we did a few things before that we probably should not have. Like, for example, we learned along the way that we really don't have to intubate early. Many patients actually, even if they have hypoxemia, they tolerate, and just keep them 1, 2, 3 days longer there, rested, proning on his own. And many of these patients just turn around and they get rid of the virus. I mean, as of today, the only effective tool against the virus biologically is the human body. Just allow the body to form the antibodies, and that should take care of the virus in 10 days, or maybe probably less. So we have learned to do that, because if you intubate early, then you get into the troubles of having an invasive device in there and the complications that go with it. We also have seen the wonders of anti-inflammatory tocilizumab. Okay, but of course, these things are double-edged swords. They can lead to reduction of the immune response also, and some infections, especially among those who linger on. We have very good. I mean, I am so happy that they have now tried to modulate the use of corticosteroids. There is a study from the US It's quasi-experimental, but it seems to fall into place of how to use methylprednisolone, short dose, early on. And in our country, tocilizumab is a fortune per vial, but we do have ready access to methylprednisolone. So a few things there, and we're learning, and that's why, as Dr. Lara said, is we are a bit more comfortable now. We have less of the shock, and I think we are doing a better job than before. Thank you.
Yeah, and thank you, Professor, for that perspective as well. Yeah, you also bring up another good point that while the latest, greatest, most fancy therapeutic might be very effective, we can't forget about the historical ancestors of the full, especially in these kind of emergency situations. Depending on the circumstance, we should keep an open mind as to what could work. I think Dr. Whelan said it very nicely when he said that CEPI is agnostic to the vaccine platforms. They just want ones that work. And I think that's how we should also look at therapeutics and other things within the classes of drugs and things. I think that's important to keep in mind. So we're coming towards the end of our time together. I think I would like to just ask our three speakers if there's something that they would just like to share that they haven't shared yet about either their experiences or the work they're doing, something that they feel might be important for the others on the line to hear or reflect on. And I'll just start with Dr. Nguyen from Vietnam. Please, ma'am.
Thank you, Dr. Burt. I think that there's one important comment I want to make is we have to go ahead the virus, and we have to think further ahead rather than treating the virus. And a session of a webinar like this can help us to collectively discuss and come up with a new intervention for the future intervention to control the pandemic. Thank you.
Yeah, thank you, Dr. Nguyen. Yeah, again, it's working together. This is the One Health Workforce Next Generation project, right? We're all trying to pitch together to train up both the next generation and ourselves as we're learning about things like SARS-2 and COVID-19. And I think I'm really happy to have both you, Dr. Nguyen, and Dr. Lara on here as obviously strong examples of excellent women in science pushing the boundaries of both education but also clinical medicine. And I hope that the other listeners that are on the line see you as good exemplars and role models for that as a great thing for the future. So Dr. Lara, would you like to have any parting comments?
I always like to say that your healthcare workers are not your first line of defense. Your first line of defense for any viral infection is your immune system. So keep yourself healthy in mind, body, and spirit.
Oh, wow. Yeah, that was beautiful. Thank you. Yes. All right. Dr. Whelan, any parting thoughts or comments from you?
Yeah, I mean, I think one thing that I think we should be hopeful about is certainly the animal data that we're seeing so far is that protective immunity is possible. It is, you can make a vaccine to this. Laura's right, she mentioned it earlier. We don't know how long it will last, but it is possible. And I think that's a ray of hope for everyone. And I think that's a probably good message to end on.
Yeah, I agree. Yeah, that's wonderful. All right. Well, with that, I think we'll turn towards the closing of this session. I want to thank everyone for a great discussion, great presentations. I always find these fascinating to learn both from our global contributors and the people in the countries where we're doing the work. I learned so much. It's really a pleasure of mine to be a part of these. So with that, I'll turn it back to Dr. Jonna Mazet from UC Davis, who is, again, herself another wonderful example of strong women in science. So please keep that up.
Wow, now you're making me blush at the end of our session. Thank you, Brian, and thank you for our amazing speakers, the knowledge you've been able to gain dealing with this terrible tragedy has been amazing. And I really thank you, Mike, for representing CEPI, and I hope you'll carry our sincere gratitude for everything that CEPI is doing, and for all of you, especially healthcare workers who are on the front lines and have family members that are in essential businesses. We really appreciate that you're all working so hard to save us and keep us safe. So thank you so much for that. We can continue to work together to be safe. We need that vaccine. We need better therapeutics. And until then, we need to protect ourselves by using the unfortunate public health measures that keep us a bit separate from each other. So, but I know we can do it if we stay strong and stay together. So Pat, why don't you take us home?
All right, so just another round, another round of thank you for all the speakers who share the experience and give us a sense of hope of what's coming up, and what the challenges as well. Once even though we have the vaccine developed, how we can ramp up that capacity and distribute that worldwide. So no one will be left behind by that with their inability to pay for it. So I'd like to announce that of the upcoming, so we have these echo sessions of sharing and try to build a community of practices every 2 weeks. So for the next session will be on June 18 in Southeast Asia, or June 17 from the US side. And the topic will be the One Health approaches addressing COVID-19 origins and spillover. So just the fine tune and come back and register and join us again in 2 weeks. So with that, I'd like to turn it back to Bruce for the last messages.